Hi there, and welcome to Coagulation and Coagulation Disorders. I'm Dr. Alex with a terrible head cold, so let's get through this as fast as we possibly can. So this is maybe the third time I've recorded part of this, but it's definitely the second time I've recorded the entire thing. So my voice sync was off the first time, so here I am recording it again. Hopefully it's a little more succinct this time. So what's going to be covered here? Well, inherent to the understanding of coagulation and coagulation disorders are the following topics. So we have to cover primary hemostasis, secondary hemostasis, and the clotting cascade. And I have to tell you, I went out on studentdoctor.net to confirm my suspicion that medical schools just aren't teaching the clotting cascade in the same way that they did 10 years ago. So I was really glad to see that because I had a really hard time trying to decide why I was teaching you what we've been tasked with teaching you in terms of the blood clotting cascade. I just don't think you need to memorize the whole cascade, but you do need to understand it. You need to understand it because if you don't understand how it works, you can't be an effective clinician. So you have to know at least a little bit about a lot of things to be able to be a good doctor. So I encourage you to go on to studentdoctor.net and read some of the comments because the comments are actually pretty funny. I think my favorite one was the one that said that nobody memorizes this unless you're specializing in hematology and oncology. But you do need to understand the steps. So with that being said, let's get to moving forward with the steps. So the basics. Blood coagulation refers to forming a clot to stop bleeding. And it's a pretty complicated subject, as you might imagine from all the hype. So what do you have to do to stop the bleeding? Well, if you're going to stop the bleeding, you have three processes to consider. You have, under primary hemostasis, you've got two processes, so vasoconstriction and a platelet plug, and then secondary hemostasis adds that platelets alone are not enough to secure the damage, so you have to have a clot. So going back to primary hemostasis, we're looking at the steps of vasoconstriction and platelet plug. So what's vasoconstriction? Well, the body gets injured, and when the body gets injured, the vessel walls constrict because there's smooth muscle in there, which causes a reduced blood flow at the site of the injury. Then the platelets start to aggregate, and they stick together and act as a plug. And that platelet activation process causes a fibrin clot to form, and that's known as secondary hemostasis. So then when we're into secondary hemostasis, a clot has to form at the site of the injury for a secondary hemostasis to be the definition. And the formation of the clot depends on several substances, and we call those substances clotting factors. So you might hear Lilo and Stitch in the background. It's a pretty good movie. I'll try not to get distracted. So hemostasis key components. What did we just say on the last two slides? Well, the vessel wall, the platelet function, the coagulation function, and then something called fibrinolysis. So the vessel wall, again, has to contract in order to vasoconstrict. And then platelet function is where the endothelial cells become sticky, and you end up with a platelet adhesion, which forms a soft plug. The coagulation cascade then starts, which results from the formation of fibrin from fibrinogen due to the action of something called thrombin, which will be clear here in just a second if you don't already know what that is. And then we have to look at fibrinolysis to regulate the formation and removal of said clot. So what's the platelets' role? Well, we've been talking about the platelets and the complete blood count. So the platelets have a big role, actually. They're all about adhesion and secretion, and then finally they are aggregating with fibrinogen or fibrinogen to form the plug. So we'll talk about platelet adhesion on the next slide, but suffice it to say on this slide that platelets secrete a bunch of junk. All right, so the next slide here, we're looking at the circulating von Willebrand factor, which attaches to the subendothelium. And you might remember from Becky Love's class what that is. And that makes the vessel sticky. And then we have some glycoproteins, and we have some platelets activated by collagen, and those platelets stretch out to cover the injury. That makes me think of a superhero, stretchy superhero. Let's see, what was the name of that movie where the guy was like, he was an old superhero and, they had like relocated all the superheroes and his whole family were superheroes and, and he was working like an insurance job and he was this great big guy. What the heck was the name of that movie? No, nobody remembers the name of the movie. Anyway, one of his kids was stretchy, or maybe it was his wife that was stretchy. The Incredibles, yeah, Mr. Incredible. So the collagen, you might think of the activated platelets as the stretchy person in that movie. They stretch out to cover the injury. And then platelet membranes expose different glycoproteins, which then bind the circulating fibrinogen. And this soft plug is then complete. And it's complete within 20 seconds after the injury, so that's pretty darn fast. Next slide there is platelet secretion. And that's interesting to think about. So we've got activated platelets that degranulate, and they release a bunch of junk, which increases the surface expression of this molecule called ICAM on the endothelial cells. And, you can see a whole bunch of biochemistry terms there. Phospholipids are hydrolyzed, intracellular proteins are phosphorylated, that's my son Liam, and arachidonic acid is then converted to thromboxane A2 by cyclooxygenase. And when this happens, aggregation happens, and more platelets can aggregate until we actually have a plug. We have a platelet plug. And then when we have this platelet plug, we end up having hemostasis. Aspirin can reduce the platelet plug. So what happens when you take aspirin? Well, it causes the platelets not to aggregate. And when the platelets don't aggregate, you bleed. So that's why people are given a low-dose aspirin whenever they have a potential for clotting. And they're also told not to take aspirin if they have a potential for clotting disorder for too much bleeding. So what are the factors in secondary hemostasis? Their clotting factors are designated by Roman numerals 1 through 13. And the factors activate each other in what's known as the clotting cascade. And the end result is that fibrinogen, a soluble plasma protein, gets cleaved into fibrin, which is a non-soluble plasma protein. So these fibrins stick together and they form the clot. So the clotting cascade has two pathways. The first one is extrinsic, and that one's activated by external trauma. So that's pretty easy to remember. Extrinsic external trauma. And that causes blood to escape from the vascular system. And this pathway is quicker than the intrinsic pathway. And it involves factor 7. The intrinsic pathway is activated by trauma inside the vasculature. And it's activated by platelets, the exposed endothelium, chemicals, and collagen. Not screaming in my house, screaming on the movie. The pathway is slower than the extrinsic pathway, but more important, and it involves factors 12, 11, 9, and 8. Then they both meet up in something called the common pathway, and both pathways meet and finish in their clot production here. And the common pathway involves factors 1, 2, 5, and 10. And if I were going to memorize anything for perhaps a board exam, I might memorize which factors are inherent to which pathway. So to be more specific, here's the clotting cascade, and you can see the damaged vessel there at the top, and then the intrinsic and extrinsic and what activates each, I would know that. And then you can see where they go all the way down until they rejoin to the common pathway, and they end up with a stable fibrin polymer. Okay, here's another recap of hemostasis. If for those of you who like pictures, this is a really nice one. It kind of gives me a headache, but some people might like this. And again, hemostasis is we're stopping the bleeding by the activation of the blood coagulation mechanism. And what's involved there? Well, you already said what's involved. What do you need to make a clot? You need your small blood vessels to work. You need enough platelets. You need enough coagulation factors. And you need enough coagulation inhibitors because we don't want to overclot, as we're going to see here later in the slideshow. That's a really bad idea. And we need adequate amounts of calcium ions in the blood. So calcium and potassium, I'm sorry, not potassium at all. Forget I said that. Calcium and vitamin K. K in this case does not mean potassium. K means vitamin K. So we need calcium, we need vitamin K. So factors concerned with hemostasis again, integrity of the small vessels. I think we just said that because your small vessels are the first line of defense. Step 1, they constrict on injury to facilitate that closure. Step 2, exposure of the underlying connective tissue of the endothelium activates the coagulation mechanism. And then step 3, adequate numbers of platelets accumulate and adhere to the injury site. Okay? And whenever they accumulate at the injury site, they form a clot. All right? And it's not magic, it's biochemistry. So step 1, there's your vascular spasm. Step 2, there's your platelet plug. And then step 3, there's your coagulation. And if you understand this slide right here, then you're way ahead of the power curve. All right, so factors again concerned with hemostasis. We've talked about platelets. So what are platelets? They're those megakaryocyte pieces of megakaryocytes, really. So their precursor cells are called megakaryocytes, and they end up being small fragments of cytoplasm. And their average survival time is 10 days, and then they get taken out like everything else. So 3 important platelet functions. Again, they plug the defect in the vessel wall, they liberate vasoconstrictors and compounds that cause those platelets to aggregate, and they release substances, we're going to call phospholipids collectively, that initiate the coagulation pathway, the intrinsic or the extrinsic, depending on which one it is. It's a highly complex chain reaction. So we're going to say here that there's 2 phases on this slide. Formation of thromboplastin by either the interaction of intrinsic factors, and that's going to be platelets and plasma factors, or extrinsic factors from components outside the circulatory system. Phase 2, we're going to convert that prothrombin into thrombin. So after thromboplastin interacts with other substances to form prothrombin activators. And then phase 3, conversion of fibrinogen into fibrin by the thrombin. And so it's a really fun little story at this point. The thrombin splits off a part of the fibrinogen and forms a smaller molecule, which is a fibrin monomer. And then those fibrin monomers join end to end in long strands of fibrin and link side to side. And so you end up with this like one united front of these fibrin monomers that are linked and bonding with everything else going on to increase the strength of the fibrin clot. And so you have that blood clot as the end stage of your clotting process. And a blood clot is fantastic if you have something that needs to be stopped. It's made up of an interlacing meshwork of fibrin threads with plasma, red cells, white cells, and platelets. I hope you can hear me over the Lilo and Stitch. I think I'm louder than them. So here's a slide that's a simplified concept of blood coagulation mechanism. Picture's worth 1,000 words. And then here's a much more complex model that I am completely disinterested in personally. And I encourage you to be interested at whatever level you find it to be relevant to your medical education. Again, basic understanding here. Clotting factors, the plasma clotting factors 1 through 13. And you can see what their function is and what pathway they belong to. This is the part where Stitch is getting run over by the convoy and the frog is kind of watching him. It's pretty awesome. He's fine, don't worry. Okay, disturbances of blood coagulation. We've got 7 slides here. So we've got 4 categories. There's an abnormality of small blood vessels that could be happening here to cause a problem with your blood coagulation. As we talked about, those small blood vessels are intricate to your, being able to vasoconstrict and stop the bleeding. We could have abnormality of platelets. That would be a major problem. We could have a deficiency of one or more plasma coagulation factors. That would be a huge problem. Or we could have liberation of thromboplastic material into circulation, and we definitely don't want things free-ranging through the blood that don't belong there. So abnormality of the small vessels would result in abnormal bleeding because the small vessels don't contract. And there could be an abnormality of platelet formation, and that could result from thrombocytopenia. We could have an injury or disease of bone marrow that damages the megakaryocytes, and so we don't end up with platelets because we don't have anything to start with. You can't make a platelet if you don't have the raw material. And infiltration of bone marrow by leukemia cells or cancer cells that have spread to the skeletal system, and those crowd out the megakaryocytes, so the megakaryocytes don't actually get to turn into platelets. Antiplatelet antibodies destroy platelets in peripheral blood, and abnormal function of platelets despite normal count could be a problem with clotting. So you got enough of them, but they're just simply not working. And we can see something on the skin called petechiae, and that's going to tell us that we might have a bleeding problem, or we might have a platelet problem. Those are small little red or blue spots, red to red-blue, and they're pinpoint-sized hemorrhages of small capillaries is what they are. And they're indicative of defective or inadequate platelets. They don't blanch when you press on them. And if you have petechiae in the presence of a fever, you should probably send your patient to the doctor. So there's a petechial hemorrhage, which is indicative of thrombocytopenia or some sort of defective platelet function. And the thing is here, kids get petechiae. Children get petechiae from vomiting, so don't get alarmed if your small child or your small child patient ends up with petechial hemorrhages around their eyes or on their face from retching when they have a viral infection, because kids vomit. It's what they do. And there's a large hemorrhage. That one's really ugly. And that one's associated with deficiency of plasma coagulation factors. And so let's look here at what happens. Relatively rare phase 1 problems, except for hemophilia A and B and von Willebrand's. We also have a X-linked hereditary hemophilia that's most common and best known, and episodes of hemorrhage in joints and internal organs after a minor injury. And then hemophilia A is considered our classic hemophilia. It's related to factor 8, whereas hemophilia B, I've never heard it called Christmas disease, maybe some time ago when I studied this, but it's something that I had to remember if I've ever even heard it. And that's named after an affected patient, and it's associated with factor 9, the Christmas factor. Yay, it's like Christmas, I've got a bleeding disorder. I don't really get that one. Hopefully it's someone's name and not celebrating the holiday. So disturbances of blood coagulation, again, von Willebrand disease is fairly common. That's a large protein molecule. What's a molecule? Molecule that's produced by the endothelial cells, and we have to have von Willebrand factor for platelets to adhere to the vessel wall. Without it, they don't adhere. So von Willebrand factor adheres to that damaged vessel wall and forms the framework that allows platelets and coagulation factors to adhere, interact, show up as a clot. And it forms a complex with factor 8 and maintains normal level of factor 8. So we really want von Willebrand factor to work. Phase 2 deficiency could be prothrombin or factors required for the conversion of prothrombin into thrombin. So there's many places on the cascade that things could go wrong. And causes of a coagulation disturbance could be problems in the liver, because they're often produced in the liver. They actually are produced in the liver, the factors. So if the liver's not working optimally, you may not get any factors. Vitamin K is required for synthesis, and vitamin K is often synthesized by intestinal bacteria. And so if there's a problem there, you might not have enough vitamin K, and then bile is also required for absorption. We could also have people who take anticoagulant drugs, which is going to inhibit the synthesis of biochemically active vitamin K dependent factors. And an inadequate synthesis of vitamin K is going to occur if the intestinal bacteria have been eradicated because of too many antibiotics. And inadequate absorption of vitamin K could observe from a blockage in the common bile duct by a gallstone or a tumor. And severe liver disease impairs the synthesis of adequate amounts of coagulation factors. So we just said the same thing on 2 different slides, pretty much 2 different ways, but you got the message hopefully. So what's going to cause too little platelets? What's going to cause thrombocytopenia? Injury of the bone marrow or disease of the bone marrow, leukemic or cancer cells that infiltrate the bone marrow, and then anti-platelet antibody, which destroys the platelets in the peripheral blood. And let's go back to that concept if it's a bad idea for things to be free-ranging through your circulation. So if we have liberation of thromboplastic materials into circulation, products of the following events have thromboplastic activity liberated into circulation, which results in intravascular coagulation. And I want you to focus here for a second on what might be going on. We're talking about diseases associated with shock and tissue death, overwhelming bacterial infections, and other causes of tissue necrosis or tissue death. And disseminated intravascular coagulation syndrome, DIC, is a model for this. It's a model for bleeding and clotting. It's an abnormal bleeding state, and so you have an activation of the coagulation mechanism due to some disease associated with shock, some overwhelming bacterial infection, or some extensive necrosis of the tissue. So you end up with all of this activation going on throughout the blood of coagulation factors, and the products of tissue necrosis and other substances that have thromboplastic activity get liberated into circulation. So what did I just say? Stuff intravascularly, things going on in the blood cell that encourage clotting, and those are now free-ranging because of this, what started out as an infection. Clotting platelets and plasma coagulation factors get used up. So because this process is saying, I need you to clot, now the clotting factors get used up, and that causes the levels to drop, so you don't have enough clotting factors. So activation of fibrinolysin to defend the body from whatever's going on that's making it look like we need to have all this intravascular clotting is going on, and these clots then, the fibrinolysin's trying to dissolve these clots before they destroy the circulatory system. So you got one process saying clot, 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 and you got one process saying no, 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 don't clot. But the net effect is hemorrhage, mostly because we've used up our clotting factors at this point. So the pathogenesis of disseminated intravascular coagulation syndrome, here's a nice little cartoon: activation of clotting mechanism, thrombosis, clot lysis, consumption of the platelets and clotting factors, or formation of fibrinogen and fibrin degradation products, and what ends up is a hemorrhage. And you can have acute or chronic. There's a nice histological slide if you're interested. And so I want to just pause for a second and think about DIC, because DIC, as I said, can be acute or chronic, but this is a very, very serious disorder, and a lot of people die from this, hospitalized patients, who started out having sepsis, or they started out having renal failure, they started out with some other infection, and they end up dying from disseminated intravascular coagulation. So, you have to treat both processes at once. You've got to try to treat the bleeding and the clotting. So how are we going to evaluate our patients to find out if someone might have an underlying clotting disorder? So I slapped this slide on here because it's questions to patients to ask before some sort of a procedure, so like surgery or other interventional procedure. And so you see here what the algorithmic approach is. If no, you don't need to evaluate. If yes, then, you need to follow all the way down to the end of this track. In box 1, additional questions to screen for bleeding disorder. Let's say they said yes, that they've had extra bleeding after a dental disease, or extra bleeding, additional bleeding more than they should have had after trauma. And so then you're going to ask these additional questions in box 1. And then here's the initial evaluation, history and physical exam. This is your laboratory test. So you got the CBC and the platelet count, PTT and PT, and fibrinogen or TT. And we're going to talk about what those mean coming up on the next few slides. This slide's just telling you what the disorders of primary and secondary hemostasis are. You can see what all those possibilities are. You might recognize the factor deficiencies, and you might recognize von Willebrand's. So we're going to ask our patients for a complete history. We're going to find out everything we can. And you can read this slide on your own on the PDF. And you're going to ask all these questions. And then we're going to ask, in terms of etiology and pathophysiology, we're going to remember that primary hemostasis involves formation of a platelet plug, which involves platelets, the blood vessel wall, and that thing called von Willebrand factor. And abnormalities can include problems in the platelet number, the adhesion, or the aggregation. And secondary hemostasis involves the formation of fibrin through the coagulation cascade. And abnormalities include deficiency of the factors, or contact factor deficiencies, or abnormalities of fibrinogen or corrective tissue, also called connective tissue. Mutations can be inherited, and you can read the rest of that. Clinical features, this is the smallest font in the entire world. Clinical features, bleeding associated with surgery, trauma, dental extractions, postpartum. You can see all the different things that can be clinical features of the bleeding disorders. And note that pregnant women with mild to moderate von Willebrand's or hemophilia A are typically asymptomatic due to the elevated von Willebrand factor during pregnancy. And some symptoms are more suggestive of either a primary or secondary hemostatic defect and can help narrow down the differential diagnosis. And the clinical features again, epistaxis, so nosebleeds, menorrhagia, melena, intraoperative or immediate postoperative bleeding, and petechiae, those all suggest platelet disorder or von Willebrand factor disorders. All right. Laboratory screening. So what are we going to do? We're going to test, our basic screening is going to be a CBC, a PT, and a PTT, bleeding time or platelet function assay. And then you can read the rest of this when you have time. But once I get beyond that, clinically, wow, I love it when Jinx starts barking. I don't even know how it could be any more like combat recording in my house today than it is. So if I have to get past CBC or PT or PTT, I'm just simply not going any further than that. I'm referring at that point. So laboratory tests to evaluate hemostasis. So to evaluate the overall efficiency of the coagulation process, I'm going to look at the platelet count, the examination of the blood smear for platelet numbers, the bleeding time, which is the time it takes a small skin lesion to stop bleeding, and that's useful to evaluate the function of the capillaries in the hemostatic process. And then I'm going to look at the clotting time, the time it takes for the blood to clot in a test tube. To evaluate the overall efficiency of the coagulation process, again, I'm going to look at the PTT and the PT. So those are my lab tests. The PTT is the partial thromboplastin time, and that's what it takes in time for the blood plasma to clot after a lipid substance is added to the plasma sample. And that's measures the time of the first phase coagulation. And then our prothrombin time, or PT, measures the time of the combined second and third phases of coagulation. So again, the PTT, partial thromboplastin time, measures the time it takes for blood plasma to clot after adding lipid and calcium. And the PT measures time it takes for blood to clot after adding thromboplastin. The prolonged time indicates an abnormality in second or third phases of coagulation. And that's often just used to measure the effects of Coumadin. So there we have PTT, measures the time it takes for a blood plasma to clot after adding a lipid and calcium. And then PT, which measures the time it takes for blood to clot after adding thromboplastin. All right, so I know that's not exactly clear, but it will be after you study it a few times. Thrombin time, on the other hand, bypasses the first two phases of blood coagulation and primary measures the level of fibrinogen. So you just add some thrombin to the plasma and it should clot. So what about the INR? Well, PT-INR is often thrown together, and that's an international normalized ratio. So it's just a way of standardizing the results of the PT. The next few slides are some Here is what factors we're talking about, and here is what abnormal indicates. So these are just here for you to contemplate. It's not something that I'm going to take a lot of time to go over here. I want you to have a chance to contemplate these when you look at the PDF. But do consider this, that these are the things that I would know if I were you. Normal PT with an abnormal PTT means prolonged PTT with normal platelets in PT suggestive of hemophilia A or B. Factor 8 and 9 assays are indicated at that point. I mean, it's time to refer. Abnormal PT, normal PTT, prolonged PT with normal platelets in PTT suggests a factor 7 deficiency. Okay, time to refer. Abnormal PT and PTT, well, then we're thinking about prolonged PT and PTT with thrombocytopenia. We are thinking about DIC, and it's really time to refer. So here's another slide of clotting disorders and labs. All right. And then the next slide is talking about intravascular blood clots. So normally blood doesn't clot within the vascular system. The pathogenesis of intravascular clotting, though, is slowing or stasis of blood flow. Then we have a blood vessel wall damage that results in an increased coagulability of the blood. And what's a thrombus then? Well, a thrombus is an intravascular clot, and that can occur in any vessel or within the heart. Once it takes off and goes free-ranging, we call it an embolus. And that detached clot is carried into the pulmonary or the systemic circulation. It plugs the vessel of the smaller caliber than the diameter of the clot vessel. So smaller caliber than the diameter of the clot, blocking the blood flow and causing it to die. Tissue necrosis happens from the interruption of blood flow, and that's an infarct. So from blood clots, you can get these from fat, you can get these from air, you can get them from amniotic fluid and foreign particles. We think of a fat embolism as someone who's had a severe bone fracture that disrupts the fatty bone marrow, like large leg bones, for example, your femur. We have to think about emulsified fat globules getting sucked into veins and carried to lungs, obstructing pulmonary capillaries. This is very, very bad. Air embolus. An air embolus is when you have like a sucking chest wound or someone's injected air into your veins accidentally. The air gets carried into the right heart and prevents that heart from filling. So it's unfortunate, but the heart is unable to pump and the individual dies rapidly of circulatory failure. The amniotic fluid embolism is devastating. It's a devastating complication of pregnancy that results from the amniotic fluid entering maternal circulation through a tear in the fetal membranes. It's again catastrophic. And then a foreign particulate matter embolism is when, let's say, someone who's injecting a substance that they maybe shouldn't, such as a substance abuser. They were going to crush an oral tablet and inject it because it's the high is better, and they don't crush it as well or dissolve it as well as they should. Then that creates foreign particulate matter embolism, and the person has symptoms of severe respiratory distress, and if not treated, will die. And then finally, a septic emboli, which is that thrombus that thrombus that forms in the pelvic vein or such structure from maybe a uterine infection. And then the bacteria invade the thrombi, as they do, and emboli from infected thrombus travel to the lungs and cause a pulmonary infarct. The bacteria in the clot invade the pulmonary infarct and then cause the lung to abscess. So nothing good happens here. So venous thrombosis, predisposing factors that are going to cause a clot in a leg vein. Well, this stuff you've probably already heard. Prolonged bed rest, sitting too long in a cramped position, impaired milking action of the leg muscles. That results in, stasis of the blood in the veins. So varicose veins or any condition that prevents normal emptying of the veins. And so the outcome is that the leg swells up and you end up with a partial blockage of the venous return. And the worst outcome is that it embolizes and goes to your lung. And you could die, or you could end up in the hospital trying to get clot busters to get rid of it. Clinical manifestations depend on the size of the embolus and where it lodges in the pulmonary artery. A large pulmonary emboli may completely block a main pulmonary artery or major branches, obstructing flow to the lungs, which is sudden death, unfortunately. And then a lung not infarcted due to collateral blood flow from bronchial arteries is the best possible option. So let's say that the clot lodged somewhere where you have some collateral circulation. You're still getting airflow. Everything's okay, except that you have shortness of breath and cyanosis due to inadequate oxygenation of blood, and you need to get your butt to the hospital. Okay, large pulmonary emboli, right side of the heart becomes distended, the pulmonary artery becomes overdistended with blood, and you end up with a high pulmonary pressure, and the left ventricle is unable to pump adequate blood to the vein and vital organs, and you have systemic blood pressure drop, and the patient can go into shock. Unlike the large pulmonary emboli, the small ones, those tend to cause symptoms. They raise the pulmonary pressure, and you have inadequate collateral circulation. But those are the ones that you hope for. If you're going to get a pulmonary embolus, give me the little ones, and hopefully I'll get to the hospital in time. Your patient's going to say they have dyspnea, pleuritic chest pain, cough, and expectoration of bloody sputum. And that's due to the leakage of blood from the infarcted lung tissue. There's a nice slide of the pulmonary embolism. There's a not-so-nice slide at necropsy or autopsy. And how do we diagnose these? Chest x-ray. It's going to detect an infarct, but not the embolus. Radioisotope scans, they inject you with technetium or something and then scan you to look for abnormal pulmonary blood flow. Pulmonary angiography detects the blocked pulmonary artery, and then CT is going to detect the pulmonary embolus indicated by the obstructed flow of contrast medium. So they're going to see where it stops. All right, there's a pulmonary angiography scan, and treatment, anticoagulants, thrombolytic drugs, angioplasty, thrombectomy. I've had multiple patients with these, so we can talk about these in class. And an arterial thrombosis just isn't that common. Its stasis is not a factor because of rapid blood flow and high intravascular pressure in the arteries. The main cause, however, is an injury to the vessel wall from arteriosclerosis. So you get ulceration, roughening of the arteriole with thrombi formation, and this blocks blood flow. You end up with an MI in a coronary artery. You end up with gangrene if it's in a leg artery, or a stroke if it's in the cerebral artery. So I say not that common. These are extremely common, but they're not as common. We don't think of arterial thrombosis in the same way that we think of deep venous thrombosis. So arterial thrombosis may be the etiology of a myocardial infarction. But what do we see as the end result? We see the person who's had a heart attack. What do we see as the end result? We see the person who's had a stroke. There's gangrene. And then arterial thrombosis from intracardiac thrombosis, you end up with a clot that forms within the atrial appendages, and the person ends up with heart failure. You can have a clot on the surfaces of the heart valves, and that's not that uncommon, valve injury. And then you can have a wall of the left ventricle, a clot, and that causes a myocardial infarction, and those can dislodge and free range around to other end organs. Not a good scene. Thrombosis by increased coagulability. The rise in the coagulation factors following surgery is implicated in clotting. And so if you've ever had knee surgery or any other surgery where they're all interested in getting you up moving around and all this kind of stuff, this is why. Because the surgery, the body doesn't know that you told the surgeon to go ahead and cut. The body still sends out the coagulation factors in response. So you've got this rise in coagulation factors. Now add to that estrogen and contraceptive pills, which stimulates the synthesis of clotting factors, and any hereditary gene mutations, and you've got a major risk for clotting issues. Thrombosis in patients with cancer from increased platelets and coagulation factors are another major pool of patients who end up with blood clots that they don't want. And so this is often how people get diagnosed with cancer. They had a deep venous thrombosis that embolized, and now we have no idea why you had that. There's no car trip, there's no plane trip, there's no family history, there's no estrogen, there's nothing, and so you start looking around for the cancer. All right, what about breaking down clots? Well, we'd be remiss if we didn't talk a little about fibrinolysis, because fibrinolysis is an antagonist to the coagulation system, as we said in DIC, and that dissolves those fibrin clots by the protease plasmin. And that limits the size of the final clots and remodels the old clots. So this process is very important. There's the fibrinolytic pathway. And plasmin function. Plasmin itself, let's go back and look at the little cartoon of plasmin. There it is, clot dissolution. Plasmin itself breaks down fibrin. And it results in fibrin split products and fibrin degradation products. Okay, and the plasminogen activators are released by the endothelial cells, and they cleave plasminogen into plasmin, and then plasmin proteolyzes fibrin into soluble fibrin, and you end up with an anticoagulant effect. Okay, and you've probably heard of tissue plasminogen activator, or TPA, from endothelial cells. Urokinase comes from epithelial cells, and then streptokinase is a bacterial product not normally found in the body, But those three together are being used therapeutically in patients with acute thrombotic disorders. And if you have acute thrombotic disorder, you want anything that's going to keep you from clotting. All right, so slowing of fibrinolysis, you can read here if you're interested, but the net effect is a procoagulant effect. Excuse me. All right, Plasminogen Activator inhibitors again. There they are. I'm not that interested in these right now. We will later in your time with us be interested, but today I'm only interested in you knowing that this process exists. It's a nice little picture. And on this slide, fibrinogen all the way down to plasmin. I want you to notice the D dimer in the bottom right corner. So anti-thrombin functions to inhibit several activated coagulation factors, including thrombin, factor 9A and factor 10A, and heparin sulfates increase the activity of anti-thrombin at least 1,000-fold. So a deficiency in anti-thrombin is seen in approximately 2% of patients who have a venous thromboembolic disease. Deep vein thrombosis and pulmonary embolism, the thrombosis may occur spontaneously or in association with surgery, trauma, or pregnancy. So why did I even show you that slide? To let you know that there are anti-thrombin functions that inhibit activated coagulation factors. So this is very important, particularly in those who have venous thromboembolic diseases, because you want something that's going to break down those clots. So tests for fibrin degradation products, I said to notice the D-dimer. D-dimer is a blood test you can run, and that's the one that I personally use and a lot of clinicians use. If I have to run anything other than a D-dimer, I'm referring this person or sending them to the emergency room if I suspect that they have a deep venous thrombosis or a pulmonary embolus. The D-dimer is a funny little test. If it's negative, you can be pretty darn sure that your patient does not have a blood clot. But if it's positive, it's sensitive but not specific, right? If it's positive, it could be something else. It could be endometriosis. It could be inflammation. It could be cancer. It could be a blood clot. But if it's negative, it's a very good sensitivity that way. So you can be not 100% sure, I think it's in the high 90s, that if it's negative, your person is not clotting. All right, so I run that one if I am in doubt. Test for fibrin degradation products, there's the FSP fibrin split products, and there's the protamine sulfate, and I'm not doing either one of them. You guys can if you want to. And finally, I diet all year, and boom, one hemophiliac, and it's back to square one. This is a really hideous cartoon, but it's the only one I could find, and I needed something to make me laugh today. So, all right, guys, this was like seriously fast, but hopefully you understand what you need to know from the coagulation cascade. Have a lovely evening. I'll see you in class.